about diarrhea. Okay? Okay, so when it comes to diarrhea, I don't know why, but the boards tend to love diarrhea. So, first off, when it comes to diarrhea, we're going to basically break this down to call it either acute or chronic. Okay? If it comes to acute diarrhea, right, you can consider it non-bloody, okay, versus bloody diarrhea. Okay? So, most of the acute diarrhea, why do people get? If you have a non-bloody diarrhea, most of the time it's going to be viral. It's typically viral most of the time, like enteroviruses, noroviruses, some virus is going to cause it, right? But then you can also have non-bloody causes for bacterial causes for diarrhea as well, such as what? E. coli, right? Campylobacter. The important thing is identifying, yes, it's probably a viral diarrhea or a bacterial diarrhea, right? If it's bloody, you should start thinking of Salmonella, Shigella, yeah, enterohemorrhagic E. coli. Which specific type do you all like? 0157 H7. If you went to India and ate samosas, you get 0104 H4. I want to be careful saying stuff like this on the internet. I love India and Indian food. Just saying, they identify the strain 0104H4 in India. That's all I'm saying. Okay. It also breeds a sugar-like toxin. Important thing is when you have an adult who comes with acute diarrhea due to the infectious etiology, what are you gonna do? You're gonna treat them with supportive care. Okay. Supportive care only. Okay. And most patients don't even need to get admitted in the hospital. So you have to make sure you're not admitting people for no reason. That's important. They look very stable, young person, got some diarrhea thrown up, go home, hydrate, and you're done. Okay? But if somebody was older, a little bit more sicker, then you'll admit them and you'll treat them. And in fact, you can give them antibiotics. Okay? If you're going to give them antibiotic, what antibiotic do we give? Azithromycin. If there's one antibiotic I want you all to remember for diarrhea for the boards, is going to be azithromycin. In fact, there's something called traveler's diarrhea, right? I mean, classically, traveler's diarrhea is for the E. coli, right? Enterotoxigenic E. coli, which is traveler's diarrhea. You typically want to treat them with azithromycin. So the boards is going to go after who you're going to do supportive care, who you're going to admit, and who you're going to give antibiotic. Now when we go into chronic diarrhea, first important thing, it's diarrhea persistent for how long? More than 4 weeks. Now do we see patients who come with diarrhea for more than 4 weeks? We do. When somebody's come with more than 4 weeks of diarrhea, what are we supposed to do? What should our thought process be? I would consider this to think about as, okay, number one, could it be an infection? What infection?
Giardia.
The only infection that can actually cause is in fact Giardia. Okay? Giardia is the only infection that can actually cause chronic diarrhea. Where do you get it from? If you go from the water streams, lakes and stuff, that's where you get Giardia from, right? Now, apart from that, what's your next step to think about? What's your big global idea? Because when you think of chronic diarrhea, it's not normally infectious. There's something wrong with the body that is not absorbing something, right?
Oh, like Celiac.
So you should think number one as steatorrhea. Okay? Steatorrhea, meaning it is fat malabsorption. Okay? Steatorrhea, to call it fat malabsorption. Okay? Or is this osmotic diarrhea? Or is it secretory diarrhea? These are your three big global headings and mindsets to think about. So number one step you want to do, clearly if somebody's got steatorrhea, they're going to tell you.
Osmotic gap.
You want to calculate the osmotic gap. How do you calculate? It's 290 minus
2 times
2 times sodium plus potassium. Okay. Now, if you have a gap greater than 100, that makes it osmotic. Okay. If your gap is less than 50, that makes it secretory. What is the only secretory diarrhea we know of? Really, at least for the boards. You can have wheezing and it can cause some valvular problems. Carcinoid syndrome.
Exposing.
Lactose intolerance. Okay. Lactose intolerance, what else can happen? People are not only, well, no, because this is talking about osmotic, okay? It's got to be some form of sugar. If it's not lactose, people are not only intolerant to lactose these days. They're intolerant to fructose. Okay, they're intolerant to fructose. They're also intolerant to sorbitol. Okay, so there are a lot of other sugars that people can be intolerant to, and therefore whenever they could ingest these things, they're going to have an osmotic diarrhea. Okay, so typically how do you test for it? But apart from that, anybody who abuses laxatives, they get a colonoscopy. What would you see inside there? A black dot, which is called melanosis coli. Melanosis coli. Okay, good. So that's it. So we know secretory diarrhea pretty straightforward. Osmotic diarrhea pretty straightforward. Now let's go into fat malabsorption, which is a bigger topic, but something that you all already know very well. So what causes fat malabsorption? What do you need to absorb fat?
Enzyme.
You need pancreatic enzyme. So if somebody's got chronic pancreatitis, that's going to be a problem, right? Okay, who else can have fat malabsorption? Huh? Cystic fibrosis, sure, yes, cystic fibrosis can do it. But again, I think cystic fibrosis causes pancreatitis, right? It doesn't really cause malabsorption directly by itself. It typically is a reason for the chronic pancreatitis. What else? You get bile coming from the gallbladder, got pancreatic juices to come emulsify the fat and it's going to digest, but where do you absorb it? In your gut, right? So if you have a problem with your gut, then you'll end up with malabsorption. What's going to cause problem with your gut? Which one? If somebody's had surgery, so if somebody's had bowel, like a short gut syndrome, right? Short gut syndrome, yes, that can cause it. Good. What else?
SIBO.
Huh? SIBO can do it. Very good. Small intestinal bacterial overgrowth. What else?
Celiac.
Celiac disease. Nice to look in the book there, this guy. Celiac disease, right? Okay. So these, what else can do it? So imaging. Right? So the way you're going to diagnose chronic pancreatitis is going to get a CT of the pancreas, and what you're looking for is calcification, essentially called saponification of the pancreas. If the CT is negative, what then? Have you ruled it out? Then you can add antidiarrheals such as loperamide. So pancreatic enzymes first, then you can add loperamide on top. Don't go for loperamide first for the diarrhea because they're going to give you that question. Solve the problem because of what's missing, give that first, right? Okay, next. Short gut syndrome is somebody who's undergone some form of bowel resection for whatever reason. What's something else very unique about short gut syndrome?
Lactic acid.
Lactic acidosis. So, what kind of lactic acid would you produce here? D-lactate. In your body, we produce two types of lactate. You have L-lactate and D-lactate. So, when I say in our patients, most of the time in the hospital, when you check the lactate, it's high. What are you checking?
L.
It's only L-lactate you're checking. You have type A, type B, right? Those are, type A is hypoperfusion, type B is because of liver problems, metformin, propofol and stuff like that. Sometimes, people who have had a short gut syndrome, what happens is, when you eat the carbs, is typically carbohydrate supposed to get to your colon? No, they're supposed to get reabsorbed in your small bowels. No carbohydrates come to your colon. But if you removed a large part of your small intestine, the carbohydrates are now going to come to your colon, and guess what? All the bacteria there are going to have a lovely meal. They're going to have a meal, and what are they going to release? They're going to produce lactic acid. And what lactic acid do they produce is D-lactate. So you can have patient with short gut syndrome who's going to come with a high anion gap metabolic acidosis, and you will not have a single identifiable cause. The only way you're going to figure this out is sending specifically a D-lactate level. Okay? So that's going to be your short gut syndrome. Good. Who gets SIBO? Scleroderma can get it. Who else? Something more, the most common condition in endocrinology. If you suspect somebody having celiac disease, how do you test for it?
Tissue transfusion.
So you want to get tissue, so you're going to get tissue transglutaminase. So tissue transglutaminase, right? Is it IgA or IgG? What do you want?
IgA.
You want to get IgA. So anti-IgA tissue transglutaminase is what you want. But when you order that test, what else do you want to order at the same time?
Yeah.
What can celiac disease do to the patient? Can it transform into something more malignant?
Hodgkin, not Hodgkin's.
Lymphoma. It can cause a maltoma, basically a lymphoma of the gut is what you're worried about. So maltoma is what you're going to look for. Okay? So when the patient is not responding to treatment, you have to start worrying about lymphoma, but also another condition. What is another condition you should worry about? Does Crohn's increase your risk of cancer? Not really. It's more to do with ulcerative colitis. But the important thing is Crohn's and ulcerative colitis is associated with something rheumatologic.
PSC. No, it's associated with scleroderma.
Patient in my age group,
Alright.
with me always having back pain, right? But ankylosing spondylitis is going to happen. So if they say the same patient's got back pain, what are you going to look for? Ankylosing spondylitis. What's your first best test to diagnose ankylosing spondylitis?
X-ray.
X-ray. What are you looking for?
Bamboo spine.
No.
Sacral.
Bamboo spine is a much late feature.
sacroiliitis.
You're looking for sacroiliitis. Good. Apart from that, you can also have eye symptoms, right? With ankylosing spondylitis, what do you get?
Uveitis.
Anterior uveitis. What else do you get with ankylosing spondylitis? Huh? Episcleritis, anterior uveitis. What else? Yes. So is pyoderma gangrenosum is not ankylosing spondylitis, but with inflammatory bowel disease. Okay. You're going to get skin lesion that you need to know about, which is pyoderma gangrenosum. See, ankylosing spondylitis, we call it AS. That A tells you all the stories you need to know. Everything starts with an A with ankylosing spondylitis. So anterior uveitis, lung apical, fibrosis in the heart, aortic regurgitation, AV block, okay, and Achilles tendinitis. Okay, those are the symptoms you're going to have. When you want to treat somebody with ankylosing spondylitis, what's your first drug of choice? NSAIDs. Are you going to give them PRN or continuous?
Continuous.
Continuously, you will give them not symptomatic treatment because you're using it as an anti-inflammatory property. How long would you treat for? About 6 weeks. If the patient does not respond to treatment, what are you going to do?
TNF.
You'll use anti-TNF or anti-interleukin 17. You're treating somebody with celiac disease, right? Or say the patient has been on a gliadin depleted diet and the patient comes and you want to do the test on them. Would these tests be positive?